Scenario: a 50-year-old male, diabetic, hypertensive. He presents with community-acquired pneumonia and is in shock. His blood pressure is 80/45. His lactates are also on the higher side. When you do an arterial blood gas, it is 3.6. You start your fluid resuscitation. So you have already given 2 liters of crystalloid or a balanced salt solution over 1 hour. And you also required to start norepinephrine because the blood pressure was not picking up by giving this fluid resuscitation. So norepinephrine 0.4 microgram per kg per minute was also started. Despite doing all this, the blood pressure is still 80/45, and now the saturations have started dipping down. It is 91% on 6 liters of oxygen by face mass. So what should we do next? Should we increase our vasopressor? Should we add one more? We are already almost at the maximum dose of norepinephrine. Should we start thinking about vasopressin or epinephrine? Or we say, no, this is probably a heart failure, so should I think of inotropic agent? Should I look at dobutamine or milrinone here? Or we feel, no, 2 liters is less, let me give 1 more liter to this patient. Or you feel, no, 2 liters is enough because the patient is started desaturating. Now the saturation is 91%. So probably my patient has gone into a fluid overload. So should I restrict? Now these are the questions which you feel every single day on bedside, and there is no definitive answer to it. And this is where hemodynamic monitoring comes into place. So whenever we manage these septic patients, we look at our hemodynamic workup. So the first important point is lactate. Now remember, always look at lactate clearance which has happened because of your fluid resuscitation. So which means you need to remeasure the lactate. Ideally there has to be a 10% lactate clearance with every 2 to 4 hours of your fluid resuscitation or your management of septic patient. This tells that the organ perfusion is improving. So always very important, remember lactate is a very important indicator of organ reperfusion. Then when your vasopressors are on a higher side, don't rely on a non-invasive BP cuff. Place an invasive arterial line because this will give you a heartbeat related blood pressure, a beat to beat blood pressure, and this is the true indicator of the arterial pressure which is there in the body. Then assess the requirement for fluid, and for this you have non-invasive techniques which are there like passive leg raising, or if your patient is on ventilator then we have other techniques. I will discuss this as we move forward. Always place a central venous access because this will do multiple jobs. This will help you in giving fluids, this will help you in giving vasopressors, this will also help you in measuring the mixed venous saturation because this is again an important indicator of organ perfusion. So SCVO2 is measured by a central line, and so please place a central line whenever you are managing such sick patients. And then look at your echo, look at your lung ultrasound because this will tell you when to add a vasopressor, when to add an inotropic agent, should I give more fluids to this patient, should I restrict fluids. So it's a holistic approach that one has to adopt whenever you are managing such patients. So when you look at your arterial pressure monitoring, now on a monitor you see these red lines coming up and down. Now what do they indicate, right? So always remember the topmost point of the arterial pressure is representing your stroke volume, and the lowermost point represents your diastole, which is directly proportional to the arterial tone. So if you have this area, this is your arterial tone and this is your stroke volume, right? So, and the difference that you see is pulse pressure. So always remember diastolic blood pressure is representing your arterial tone, which means if you have a vasodilatory state, the arterial diastolic blood pressure will keep on going down, and that is what you see in septic patients. The systole with the help of your vasopressor may be around 100, 120, but the diastole lies around 40, 42. So this tells me that it's a vasodilatory state. The SVR is very, very low, and this is what is very important when you look at organ perfusion. So you add your vasopressors, and what will your vasopressor do? It will help you in increasing this pulse pressure. So your systolic pressure may rise and the eventual pulse pressure may improve. And with the help of cardiac ultrasound, you decide about fluid and inotropic agent. And very beautifully, this has been depicted in an article by Professor Tibull. Now, Professor Tibull is considered a very important author when it comes to hemodynamic monitoring, and he has written what are the techniques of less invasive hemodynamic monitoring in critically ill patients and what is their present role and how to interpret these arterial lines. What about central venous pressure? Now we remember during the early days of teaching, we used to say central venous pressure should be around 10 to 12 millimeters of mercury. So somebody walking into the intensive care unit, if they saw a central venous pressure, a CVP pressure of let's say 5 or 6, it was a random answer, give fluids to this patient. Now this concept has been challenged. So if you look at the FENIS study, now this study looked at the global inception cohort study, and they looked at what is the maximum practice of clinicians in terms of central venous pressure. So what they found was that static variable used to indicate fluid challenge was used in 785 patients out of 2,213 patients, where majority still used central venous pressure as an indicator of the fluid responsiveness, or I would say an indicator of fluid challenge. Others still use pulmonary artery occlusion pressure, some use the global end diastolic volume, and other techniques were also used. In this similar study, they found that in 945 patients, no variable was also used. So it's a mixed practice between clinicians, and we all know that we use these hemodynamic monitoring to indicate the fluid challenge. Now, in another important article, now this was by Professor Paul Marek, he looked at the concept, does central venous pressure actually make any sense or not? And what he did, he looked at the systematic review, and he named his article as Systematic Review of Literature and Tale of 7 Mayors, where almost 24 studies were enrolled and 830 patients were there, where 5 studies compared central venous pressure with the measured circulating blood volume, whereas the 19 studies looked at central venous pressure and a change in the central venous pressure because of the fluid challenge. What they found was that yes, central venous pressure to certain extent helps in diagnosing the right ventricular dysfunction. It also helps in optimizing the mean arterial pressure. But the most important thing, it is not very helpful in predicting the fluid responsiveness. Now, if you look at the other side of the slide, where they looked at, is cardiac filling pressure an appropriate predictor of fluid challenge? So here what they found was that absolute CVP values, if you are targeting, this is what I said, somebody walks into the ICU, sees a CVP of 5 and says give fluid. No, it has no value in terms of assessment of fluid responsiveness. A low CVP value or a high CVP value does not make much of a difference. Yes, we know it is a determinant of venous return, it is a determinant of organ perfusion. So always look at a trend in the CVP, always look for a change in the CVP rather than an absolute value of CVP. It also depicts certain concomitant changes in cardiac output. So a static number is not important. You always need to monitor the trend of CVP. Is my CVP increasing with whatever therapy I am doing? If I am giving fluids to this patient, is my CVP increasing or no, it is static? If I am giving vasopressors to my patient, what is happening to CVP? That is where the role of CVP is in the present scenario. So the question to be answered is, should we throw away this concept at all? And should we actually think about doing something else? And this was beautifully answered in this paper by D. Marek, where he looked at, should we measure the central venous pressure to guide fluid management? And he said there are 10 important